Good afternoon or good morning, depending upon where you are. We have hundreds of people joining us on a webcast and lots of people here at the PCC headquarters, 1101 Connecticut Avenue. I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and we are thrilled today to be releasing our 2024 evidence report. We've been promulgating evidence reports since 2012. And this report was developed in conjunction with the Graham Center, who we have been working with for many years and really enjoy our partnership with them, and with Simple Healthcare. For those of you who may not know the Primary Care Collaborative, we are an organization that is focused on improving the nation's health by strengthening primary care and support advanced primary care models like the patient-centered medical home, but seek to improve the financing that supports those models so they can be as effective as possible. I want to thank this afternoon rather, not only the co-authors from the Graham Center, who you will hear from today, and from Simple Healthcare, but also our supporters. 5 organizations have stepped up to make this report possible, and we're so incredibly grateful for their support. They are West Health, and we also had a reviewer from West Health on the report, the American Board of Family Medicine, a longtime friend of PCC and a member, Innovacer, also a longtime member of PCC and will be one of our speakers today, the American Board of Internal Medicine Foundation, and the American Board of Medical Specialties. So a couple of quick takeaways before I turn it over to the researchers to get into more of the granular detail. Like the Congressional Budget Office, we have found that primary care-centric ACOs, and we have a definition of what that means, are delivering incredible results. And Medicare beneficiaries are pleased to be in those arrangements and are benefiting from them. However, the number of primary care physicians and the type of primary care-centric ACOs is declining, as is the percentage of Medicare beneficiaries that can avail themselves of these high-performing ACOs. We believe that we need to take some policy steps to reverse that decline, because we see one of the highest performing value-based care programs is not growing, and we really believe that we need to reverse that trend. In our report, we also identified 25 MSSP ACO bright spots that have a majority of primary care physicians and high savings, and go into 3 case studies to get behind the numbers and give you all a more in-depth understanding of what drives their success. We will have one of those ACOs today presenting. Then we'll discuss the impact of the findings and what they mean. And finally, we will discuss how policymakers can take steps to expand the prevalence of primary care-centric ACOs. So before I introduce Allison, let me just flash our collaborators on this report and our supporters. All right, now let me introduce Allison Hufstadter. Dr. Hufstadter is the medical director at the AAFP Robert Graham Center and a practicing physician at Fairfax Family Practice. As medical director at the Graham Center, she engages in primary care research that acts as the foundation for health policy at federal and state level. Allison will be providing background about ACOs, particularly the MSSP program, and provide some insights that she and her research colleagues gained from the 3 case studies that they do. Allison, let me turn it over to you.
Good afternoon, everyone. As Anne said, my name is Allison, and I am happy to share with you some of the background and our case reports from this year's PCC evidence report. Now, let's start with the common basics, because ACOs might not be the most understandable language for everyone. And what we mean in this report by an ACO is a group of clinicians, hospitals, or practices that really share financial risk for a group of patients or accountability. ACOs come in many different flavors, anything from commercial, Medicare, or Medicaid. There's also types like REACH or Flex that you might have heard about But for our report, we wanted to focus on the most common type of ACOs, and that is the Medicare Shared Savings Plan ACOs, or MSSP. MSSP ACOs are part of the normal fee-for-service, but if they meet their benchmarks and they have shared savings at the end of the year, they can benefit from financial gains as being part of an ACO. Let's look through the history of ACOs and when they started. Now, 2012 is not when ACOs were first thought of, but they really went into common action in about 2012 in earnest. And so what we saw at that time was that 55% of the US population lived in an area with an ACO. That's about 114 ACOs at the time, covering every state in the United States. Of those, we saw that ACOs were more likely to form in areas that had higher cost of care, had higher poverty, had some pre-existing work with a managed care of any type, not necessarily an ACO, but had other contracts with the federal government, and there were fewer physician groups in these ACOs initially. They were more hospital-led. In fact, only 20% were physician-led at that time. Since then, we've seen that grow to over 480 ACOs, most recently in 2023. ACOs peaked in 2018 with 561 ACOs. They serve most all states now. At least every state has one that's commercial Medicaid or MSSP, but most states have MSSP at this point. They are no longer in areas that just have high poverty or have pre-existing managed care. What we've seen over the course of time is that they're fairly equitably distributed throughout the United States in terms of both the areas that have higher cost of care and lower cost of care, have poverty rates, and we've also seen a significant increase in the proportion of ACOs that are physician-led, up to 45% at this point in time. In our 2018 report, you can see several factors that led to successful ACOs, and that included leadership and culture, specifically having a culture of working for the patient in front of them and aligning what is a priority of the practice with the priority of payers and incentives within that actual clinical setting. Of course, having previous experience with any type of managed care or a care contract led to better success within the ACO organization. Health information technology can be an enabler or a challenging barrier for ACOs. Specifically, health information that allowed for actionable data quickly found to be highly related to success within an ACO. And of course, organizational and environmental factors played a role. What we see, the alignment with all of these factors of ACOs, is that they overlap and align with high-value care, with team-based care, with care coordination and care management. And oftentimes these factors have continued to provide for successful ACOs until 2023. The literature shows us that we have found more primary care within an ACO leads to more savings. Outside of the primary care specialty alone, if physicians are in leadership roles, there tend to be higher savings for ACOs. Not surprisingly, the longer that a participating ACO is within the environment, they are more likely to have savings. So from year one, you might have around $150 per beneficiary savings, but that triples by year 3. And again, these numbers might seem pretty small, but let's just take one case example. If a clinic has 15,000 beneficiaries within their ACO, that $474 turns out to be $7 million of savings over the course of 1 year. What we also see is that smaller practices with fewer overall clinicians had more savings than those with larger practices. What we hypothesize here is that larger practices might include more hospitals and may include more subspecialists, which tend to have higher costs of care. And finally, practices and ACOs that focused on areas of patient benefit had larger savings. This comes from things like annual wellness visits and making sure that patient screening tests are up to date and managed with the patient in the clinic when they're available. Let's jump into our case studies. Before I talk to you about the 3 clinics which we interviewed, I'd like to talk to you about how we selected the ACOs to interview. For all ACOs that reported to the MSSP in 2022, we reported the number that were PC-led, so primary care led. We weighted the proportion of primary care clinicians over all of the primary care physicians within that practice. We also weighted the social deprivation index of their community, their quality metrics, and their savings over time. And the compilation of those 4 different metrics led us to go and interview the ACOs with the highest proportion of primary care and the most savings over time. We sent out email invites to leaders of ACOs and asked if they'd be willing to participate. And from that, we came up with 3 case studies: the Louisiana Enhanced MSSP ACO, One Health Nebraska, and Community Health Provider Alliance. From our first ACO, the Louisiana MSSP Enhanced, we interviewed 2 leaders, and what they said about their ACO success was pretty universal. What we saw was it took time to achieve savings within that ACO consistent with previous studies. They initially started off with broad goals to meet their metrics, but they found that focusing on too many things at once didn't lead to success. So instead, they changed their focus to lead on 1 or 2 actionable focused goals. And with that, clinicians were able to narrow in and meet success markers over the course of time. They also integrated technology to hope for better success. They provided an app that allowed for basic care to happen within the clinics, and it essentially showed clinicians and teams what care was missing for their patients that were going to be seen that day or from the patient panel at large, and was able to target interventions for the patients that needed to have basic care happen. The Louisiana MSSP ACO also provided practices with a practice transformation specialist. This essentially was a facilitator, someone who could come to the practice and say, how do we best meet the goals of the ACO and tailor them to the actual practice that needs to make changes. They noted practice autonomy, which was shared by many of our interviews, as a very important aspect of maintaining the clinic's individuality, but tailoring those needs to meet with what the ACO was trying to achieve. And finally, one very unique component of the Louisiana MSSP ACO is that they sent out postcards before the holidays one year to remind patients of the holiday hours, recommend that they get their refills for medications ahead of time. And what they saw was by doing that small gesture of a postcard, they reduced ED visits and hospitalizations over the holiday time period. Next, we interviewed 2 leaders from One Health Nebraska. They said that their ACO is owned and governed by physician shareholders. But again, they really thrive because there's autonomy of each of the clinics. Each clinic has a physician champion, a care coordinator, and an administrator who work towards the ACO overall goals. By having these small teams that are easily accessible and understand the ACO goals, each clinic could tailor their own needs to meet and achieve the goals of the ACO. Interestingly, One Health also had health information technology as one of the primary keys to being successful. And they note that the American Board of Family Medicine Prime Registry was essential for them to be able to both have access to data in a quick way and report their ACO metrics at large. Without that, they would have had many different EHRs to try and report from that would not have been easily synthesized. In addition, for family physicians, this was free. They also took a patient-centered approach. And what we found quite remarkable about this ACO was that they really wanted to become the place where patients went to find their primary care home. They noted that patients were their focus and their mainstay of the work. If the ACO goals did not meet what patients needed, they weren't interested in pursuing it. They really wanted to improve the well-being of their patients and improve clinician satisfaction. Finally, the Community Health Provider Alliance was our last interview. From this operation, we found that they had a lean group of 4 employees in 2020 that really took ownership of the ACO. Now that's grown slightly. They now have 20 employees, but having a small group of leaders allowed for all of the clinics, the physicians, the teams to have access to leaders who could help them and enable them to make changes within the practices that met the goals of the ACO. They also noted that community health centers, of which the large proportion of these clinics are, have really challenging and complex patients. And so in order to make sure that they were both disseminating and displaying the complexity of their patients, CHPA hired professional coders to go in and ensure that the complexity was reflected in the codes that were provided by the clinicians in these clinics. Similar to our first interviewee, the Louisiana Enhanced MSSP ACO, This group had a clinician-led transformation team. They took data that was actionable on a quick and meaningful basis and used those data to provide insights into what to change and what specific areas could be improved on as they move forward to meet their benchmarks. CHPA noted that there had to be an alignment between the clinic staff and the leadership of the ACO to really get to success. They wanted all of their team to be on the same page. And finally, one very unique solution that CHPA provided was learning labs. They would allow clinicians and teams to come together and learn from one another over these learning lab sessions so that shared practices could be brought forth and used between many of the clinicians within their different ACO practices. Thanks so much for listening to our background and our case studies. I'll hand it back to Anne.
All right, David is the founder and CEO of Simple Healthcare. He's a healthcare researcher and entrepreneur, and he's committed to transforming the delivery and payment system. Many of you know David because previously he was Chief Research and Innovation Officer for Health Management Associates, and prior to that, Chief Strategy and Chief Research Officer for Levitt. He has a PhD and a law degree, and we so enjoyed working with David. He is a real master and provided all of our quantitative analysis.
Thanks, Anne. It is great to be with you today and talk a little bit about what we found on the quantitative side. So we're looking at the Medicare Shared Savings Program. So it's just a subset of all of the different organizations that have been involved with APMs, but obviously it's the largest program that's there. And when you look at this, this is just a series of distributions of ACO performance over time. Basically, a bunch of histograms where you can look at this. When you see all of the different years, you'll see that there's 2 in 2019. That's because in 2019, there was a second performance period with changes to the program. And so that's why you're going to see some of those things there. But when you look at this, there is a distribution. Every year, there are organizations that do very well. And so that's on the positive side. So you want to have positive savings. So people that are saving up to 20% relative to their benchmark. And you also have people that are losing in the teens, in the negative teens. And so there's a fair range of performance that's there. Ideally, what you would see with organizations is that people come in and they start to perform and they start relatively, they might be low. Maybe they're losing some money in the first year or 2 years, then they're close to break even, then they're starting to get some bonus payments and it starts to creep up over time. That's the story, and there are certainly ACOs that have lived that experience where they have improved over time. There are also others that are kind of random, where they lose a little bit this year, they win a lot next year, they lose a whole bunch the year after that. So there's randomness that goes into all of these outcomes. Sometimes you have a very clear story where you say, we did A, and then we saw the result B. Other times you have organizations that say, we did A, we did not see the result B. And so there's certainly questions about how well people are deploying any specific intervention. Also, I will say that there is a distribution no matter who is leading that ACO. So whether it's primary care centric with a lot of primary care doctors, whether it's physician-led, whether it is hospital-led, there is a range of performance that you have within that. And so what we're trying to do is go behind the noise a little bit and get a sense of how they're doing. Another thing that we looked at was the social deprivation index. So this was trying to understand what sorts of patients were these ACOs caring for. So the social deprivation index is looking at things like access to fresh water, or not fresh water, fresh fruits and vegetables, so food security, housing costs, all sorts of things like that. And then creating a measure of the community that people were living in. And we wanted to understand also, are ACOs going towards a specific population, either a healthier population or maybe a sicker population, and seeing how that related to performance. As you can look here, there is a very wide distribution. So the SDI ranges from 0 to 100, and you can see that ACOs basically cover that range. And so ACOs are covering the entire population of the United States in different areas, and they're not gravitating just to a higher SDI or a lower SDI population. So then the question is after we looked at that, what is the correlation with performance? If you take care of a patient in a higher income area, if you take care of patients in a lower income area, how likely are you to see positive results? Well, this is kind of a messy chart. And you don't have to be a statistician to know that there is not a strong correlation there. And that's one of the things that we did find from this, is that there is not a strong relationship between the SDI of that population and the financial outcomes. We thought that maybe there was a story there that would be like, oh, well, you really need to go and take care of lower income people, and that's going to increase your odds of success, but it really was not strongly correlated with any of the different ways that we looked at the SDI. So certainly there's more work to be done to understand these populations, but it also suggests that maybe the current approaches with risk adjustment and otherwise are addressing some of those needs for at least the MSSP population. The next thing, though, is primary care. Obviously, we've been thinking about primary care and talking about this, and what is the role of primary care as it relates to taking care of a population? And so this is another histogram, or they're called strip plots, but kind of sideways histograms looking at the percent of physicians who are primary care. So every ACO has a group of clinicians that are responsible, that are the attribution go through those patients. And what we did is, in the numerator, it was all primary care physicians, and the denominator was total physicians that are there, and it's just a simple score. What is the percent of all of those physicians that are primary care? And you can look at the range here. So it is not normally distributed. There is a subset of organizations that are very heavily primary care focused, and in fact, there are quite a few ACOs that 100% of all of the physicians are primary care docs. You also have some that are heavily specialist focused. So these are the ones down at the bottom, that below 20% of these doctors that are participating in the ACO are primary care. So quite a large distribution. One of the other things that we learned is that this is not consistent for the ACOs year over year, because typically people think of an ACO and it's a relatively static group of providers that are coming together. But that is not always the case. This might be one medical group and it's just that same medical group for the next 10 years. But other times people are bringing in new practices. And so sometimes people will start with a primary care and then they'll bring in a bunch of specialists, or vice versa. And so there's actually a fair amount of movement that we've seen year over year with just how much is around a primary care model. So we, of course, have to adjust for all of that as we start to look at some of the results. But here is now what we find. And so let me explain this chart to you. This is kind of a key finding for this report. What we did is, for every year, we took quintiles of all of the ACOs based on the percent of their physicians who are primary care providers. So what that means is that changes every year, but if we go back to this previous chart, we see that top group that has almost 100% is primary care physicians, that would be in the 5th quintile, the top quintile that's there. And then those that are in the bottom are the ones that are relatively few. We then took those quintiles and said, what is the average performance score? Again, positive is better. When you look at this, you see that year over year and increasing over time, the higher quintiles had significantly higher savings rates. So as you look at this, you can see that, first of all, the general trend has improved over time. The black line is the yearly median performance across all ACOs, and that has improved over time. So as a whole, the program is starting to do better. But we're also starting to see a larger separation with much higher performance at that top quintile. So in 2022, the top quintile, so that was there's a high percentage of physicians that are primary care doctors, they had an average savings of over 6%. That is very substantial. If the whole program had a 6% savings, there would be rejoicing at CMS. Now, at the same time, though, we've seen a concurrent trend. One is that this has been known. People have generally known that primary care is how you can have financial incentives that align with managing a population. And the short answer of that is the model for that is that the high-cost care takes place where primary care doctors are not involved. So if you're admitted to the hospital, that's going to be very expensive. But if you're a primary care doctor, you're going to do a lot of outpatient work. And if you do more care in the outpatient setting, you can get paid through that. But then you will also hopefully eliminate potential high-cost treatments. And then you'll have the opportunity to see savings afterwards. You get paid more in the short term, and more in the longer term. And that's been conceptually known for a very long time. From the very origins, even before the MSSP was created, people kind of knew that this was the model. Now we also have clear data that suggests that the more primary care doctors you have, the better you tend to do as well. It's sufficiently strong that if this were an FDA trial, this drug would be approved. But we have not seen an increase in the number of these organizations that are predominantly led by primary care doctors. And so that is a concern that we've seen, is that, yes, there's evidence that suggests that you do better, but the organizations that don't have a high primary care percentage are not increasing their primary care docs, and we're not seeing new primary care centric ACOs join the program. So that's the challenge that we are seeing. One final slide is, this is for 2022, and I'm breaking apart all of those quintiles. So in the green, you see what percent of all of those ACOs, or what percent of their physicians were generally were primary care doctors. And so in the lowest quintile, only 24% were, and in the highest quintile, 87%. Then in the dark blue, you see what percent of those not only saw savings, but qualified for a bonus payment. There is a dose response with this. The higher the percentage is, the higher that not just see savings, but see the bonus payments that come with it. And with that, I will pass the time back to Anne. Thank you.
Thanks so much, David. Okay, now we've got the evidence on the table. And I did want to make one point that I'm not sure came through when Allison was presenting, which is that we were not able to determine where PAs and NPs were practicing. So the analysis is based on primary care physicians because the public use file does not make that determination of who's in primary care and who's in specialty care. On a going forward basis, we'd really like to bring in PAs and NPs that are practicing in primary care and have a more comprehensive picture. So I just wanted to make that point. So let me bring my fellow panelists up. And again, thank Allison and David for their contributions to the report. First, I'd like to welcome Anthony Wright. He's the new Executive Director of Families USA, and they are a PCC member. Before joining Families USA, Anthony served 22 years, and many of you knew him as Executive Director of Health Access California, where he led state efforts to win patient protections, fight budget cuts, invest in the safety net, expand coverage, and advance equity and prevention, all in a good day's work. Thank you, Anthony. Please, Dr. Jain. Dr. Anil Jain is Chief Innovation Officer at Innovacer, another PCC member and a technology company that helped facilitate success for one of the case study ACOs. At Innovacer, Dr. John leads initiatives that advance Innovacer's platform capabilities and help health system partners and practicing clinicians leverage the platform to connect all the various IT systems so they really can have a full care ecosystem. And then finally, I'd like to welcome Dr. Darren Menard. He's Medical Director of the Louisiana MSSP Enhanced ACO, which is one of the ACOs featured in the report. He's a practicing physician in Scott, Louisiana, and the medical director, as I mentioned, of that Louisiana ACO. As medical director, he works in partnership with Aledade to expand the delivery of value-based care across Louisiana. Darren's practice is also the only Louisiana practice in 2023 to receive the Million Hearts recognition for their efforts on hypertension. So let me now ask the first question of Anthony. I think we would all agree that it's critical to continue to evolve the traditional Medicare program and value-based payment within that program to better meet beneficiary needs. What do you see as the promise of MSSP ACOs? What do you see as the contribution that primary care can make? And do you think ACOs are delivering on that promise?
Thank you for everybody for having me and for inviting me. Again, my name is Anthony Wright. I'm with Families USA, the longtime healthcare consumer advocacy organization, and as Ann said, I have my own quarter-century career in state-based health advocacy in New Jersey and most recently in California, where I did do a lot of work around the promotion of primary care as part of trying to advance the goal of not just affordable but quality health coverage for all. I think it is, the average person doesn't know the term MSSP, doesn't even necessarily know the term primary care, and that's not, you don't see people in the streets with placards that say primary care now. But what they do care about is their relationship with the healthcare system, their relationship with the provider, having a trusted relationship, having a focus on prevention to keep them healthy, so they're not in the emergency room or having significant care needs, or if they do have significant care needs, they have a chronic condition that care is coordinated. That what patients experience is a very complex and confusing healthcare system, and they need somebody to be in their corner as they try to navigate through it. And so I think, and this is doubly so for those in Medicare, who typically have needs because of age or ailment, and so I think that's why I think it's important to have these models and show, and I appreciate the evidence report of where things are working or working better. I think there's still more work to do with regard to, and to see that part of that secret sauce is a focus on primary care, is the metric of, what percentage of your network of your group is primary care. It may not be the perfect metric in terms of I hope that what that actually means, or is at least a proxy for, is the ability to actually just get in and see your primary care doctor, that you and that you can have that relationship both in the wellness visits in the front end and sort of that ongoing check-in, especially with regard to chronic conditions in the back end, and to show that actually does produce savings is, I think, a positive step to see. Then how do we continue to evolve the financing? Because right now that is not actually the natural way that our system is organized. That the financing structures are not quite there, and we need to do more to incentivize an investment in primary care, which has been underinvested in, and do more to get that those things that primary care and advanced primary care models do, that actually is paid for and invested in, so that we can actually yield the savings on the back end.
Well, thank you for your remarks, and also for Families' leadership to bring consumer organizations together to really consider how payment changes might get them the kind of care they want for the folks that they're advocating for. So appreciate, Anthony, all of the work that's happening at Families. Darren, as medical director at the Louisiana ACO, you have an incredible stats. Let me just make sure everyone knows. We saw them up there, but let me just repeat them. 15% savings rate, even higher in 2023. I think you're almost up to 17%. Your quality score is 91 out of 100, and you're serving a very vulnerable population. On the social deprivation index, you're 80 out of 100. So tell me a little bit about how you interact with practices. What role does the ACO play vis-a-vis the practices? And how do you enhance care and reduce costs? And just sort of what do you do versus what the practices do?
So good questions. I think that one of the things that we do really well in our ACO and our accountable care organization is teamwork along the basis of all of our practices. Have a representative at our board meeting every month, and they not only attend the board meetings, but they participate heavily to start creating the kind of care that we want for our patients. That is a big factor in getting to the point of savings and becoming innovative in how we think about caring for our patients and things that we can do to increase savings in the cost of care. Having said that about our board members, it trickles down to our staff in our offices. So with my participation as the medical director for the Louisiana ACO, it has, I have developed a lot of trust with every other practicing physician in the ACO because I'm still practicing medicine. I see patients 3 days a week full time on those days, and I do my ACO work on those other 2 days. And just being in battle together with all the other docs across the state.
Did you say battle?
It is definitely a battle. We related to doing medicine as being on a football field. If we can do the work as primary care, being on the offensive line, the defensive line, in the trenches of day-to-day care, doing the same thing over and over again, establishing those fundamentals that provide the best primary care, and then not only establishing them, but actually fundamentally doing them day in and day out with every patient has made a tremendous difference in the care for our patients. So the idea of being able to have the data coming to us as a practicing physician, and then being able to see that data in comparison to other practicing groups in our organization has made everyone very competitive to get better and better every year, year in and year out. So we started off the ACO journey in 2015 with a couple of years where we didn't make savings. And then in our third year, we finally achieved the savings, primarily because everyone started getting anxious about the fact that we were not making savings. And so we came up with an initiative towards the end of that quarter, the last quarter of that year, where we started looking at our ED costs. It was just too much. Just calling the patients after they went to the ED was not enough. So we worked very hard at all the practices, really wanted to make an extra effort at keeping those patients out of the emergency room in that final quarter. And we made a goal if every provider could prevent one ER admission per week for the rest of the year, that we would get to savings. If we could prevent one hospitalization per provider per month through the rest of the year, we can make savings. And all we have to do is get that goal in the mindset of these practicing physicians, and we accomplished the goal. And that really started the trend of how do we decrease cost of care more and more year in and year out. And to be honest, we just continue to do the same work over and over again every day. We have some very territorial, respectful primary care physicians all over the southern part of the state that really want to work hard to provide better care for our patient population.
Super. Well, thank you so much. Last but not least, Dr. Jain, in each of the case studies that we detailed in the report, technology had a critical role in the success of the ACO. Can you reflect on what kinds of technology solutions you see as most successful in the ACO space? And you work with a lot of ACOs, you work with a lot of health systems. How do you go about developing such solutions?
Sure, that's a great question, Ann. First of all, if primary care is a drug and a dose-response drug, then technology is the delivery mechanism, right? So that's number one. When you think about technology, most primary care physicians, including myself, sometimes have a very negative visceral reaction to technology, okay? So what does this mean for ACOs? Well, the technology we need to introduce to help these providers. First, we have to have a population health management platform. And there are three components to that. First, you need to bring all the disparate data together. So the claims data, the EHR data, the data that's coming from the community, whether it's lab data, medication data, hospital admission data coming from the HIEs. All that needs to be brought together so we have a single unified view of the patients that we're trying to take care of. The second thing is that all that data then needs to drive actionable insights. There's lots and lots of data, but we typically say in primary care, We're data rich, information poor, right? So that it needs to be converted into information. What is the most relevant things that we need to think about? Who are those patients who are going to be likely admitted to the hospital or to the emergency department if we're not careful? So those analytic insights are a key component of what we need from a technology point of view. We also need to know who are the patients who are going to get into trouble if we're not careful. So between advanced analytics and now emerging in a big way is AI, that's going to be the second component of that technology population health management component. The third piece is once you have the data and the analytics together, you need to be able to bring all that together to give some transparency and visibility to the providers. I would love to be in a position where every single primary care provider grabs a cup of coffee or their favorite drink in the morning and is able to see a dashboard with all the things that they need to worry about for their patients. Almost like a cockpit view. We're getting close, but that would be the utopian view of primary care. That's the first component. The second component is once you have this population health management platform, how do we reinvent the ways that we do things? How do we reinvent care management, knowing how to coordinate the care among the most vulnerable folks, taking into consideration their social determinants. So we know who might need cab fare, who might need a little bit of extra time getting to the office. Patient engagement. These days, I know my adult children don't want to be connected to by their doctors the same way I do, right? They want to be texted. They want to perhaps get their medical information on Instagram or TikTok or whatever they do these days. So that care management, that care coordination, that patient engagement, those optimized workflows need to be, in some cases, data-driven. But I don't know about you all, but if I'm in primary care, there's a bunch of things that I do that's considered low-value work. Maybe that can be done automatically by AI agents. That's happening throughout the entire industry. So that middle component, that workflow optimization, is a key component of technology. The third one, I think, is really critical, is to not only help the primary care providers be successful at their ACO, MSSP arrangements, but they also need to have visibility. You know, they say no money, no mission, right? They need to get some visibility into what's happening within their ACO from a forecasting point of view, all the way to how to optimize those shared savings. That's the sort of the technology requirements. Getting to your other question, Anne, about what is a company like what we do at Innovacer, how do we go about building this type of stuff? And this also applies to our peers. Well, the first thing is to get to know the space. You need experts who understand ACOs, who understand MSSPs. Like what Allison and David were sharing with us earlier. What does this data tell us? What are the pain points that ACOs and folks in ACOs are dealing with? And then you use the people, the process, the policies to dictate the kind of technology you need. And that technology needs to be user-centered and needs to be agile. So we're not developing something today that, you know, we don't want another generation of EHRs that don't work for us. We really want to have augmented, adjacent technology that clinicians will embrace. And then the final component of doing this is to make sure we understand what the outcomes we're trying to derive. If we don't know what the return on investment for technology is, how in the world are we going to afford it? And then the final piece, and I think PCC is doing a fantastic job of this, is to make sure that this technology is affordable, which means we need to be advocating for the reimbursements that allow primary care providers to embrace this type of technology. Let me pause there, Anne, and see if that helped answer the question.
Oh, terrific. Thank you so much. And many facets of my question, so I really appreciate it. You know, often described as the secret sauce of primary care is the relationship between a person or a patient, if you prefer, and a primary care clinician. So I'm curious, from each of your vantage points, you know, how do you think that primary care relationships might be contributing to the outcomes we're seeing in these high-performing ACOs? You know, relationship's a big term. Yeah. So if you could just reflect a bit on that. Want to go first, Dr. Miller?
Yeah, I can talk to that. Basically, I really like the point of understanding that every person deserves the care that they need, and the care that they desire. One of the things that we focus a lot on is really trying to keep patients home for the holidays. It's kind of our initiative in this final quarter of the year. And it's to really touch base with them on a regular basis, especially our patients that need it the most, that are the sickest patients in our population, using the data, the data analytics from our ACO Alidate and working towards diving into those sickest patient populations and touching base with them on a regular basis. That primary care of interacting with those patients from our entire team aspect really helps the patients understand they have a home, that they can count on us to be there for them in their most important needs. But it's more than that. This preventative care space that we've been working towards these last 7-8 years has really allowed the patients to know that they can call us first for anything that they need. And that really helps to drive them to stay out of the hospital. So primary care is just that. It's that one-on-one, person-to-person basis point, and we're just expanding it with the ACO into the population of every primary care provider talking to their patients in the same way, getting the time to spend with them in this value-based care setting, and getting paid for it. These ACO, Medicare ACOs are really beneficial for us to be able to do the services that we need to do.
Thanks.
I think that one of the things that we've talked a lot about in the broader political sphere is the sort of diminution of trust in our society. And I think that this may be one of the things that we need to sort of preserve, is that level of trust, because, whether given the misinformation that's out there, given lots of different cues about what is healthy and what is not, having that relationship matters, and that depends on that depends on a relationship. And I think with trust also comes responsibility. That in a primary care model, it's not the model of just a patient on either the doctor on a hamster wheel or the patient on a conveyor belt that just have to get dealt with in a while. That this person is your responsibility. This patient is your responsibility. So how do we provide you with the preventive care? And it might be, and I appreciate what you were saying about like having the goal of like let's keep folks out of the emergency room. And I'm sure it's not like we're not restricting people from the emergency room, because they're sometimes people do need to go there. But frankly, no patient wants to spend their evening in an emergency room. Nobody binge shops in an emergency room. It's they also have that goal as well. And so what can you do? And it could be something simple like just making sure people have their flu shots, which could reduce like just hospitalizations in any given winter, especially for a vulnerable population in Medicare. It could be something like just, especially with chronic conditions, maintaining somebody's asthmatic condition or diabetic condition, which if not maintained, could lead to an ER visit. And then frankly, what you could do to even get people in to a practitioner that they may need sooner, because if that appointment is delayed, you can't get that appointment for several months, then it's either in that time that people give up and go to the ER, or by choice, or even sometimes by not because of the situation. And so just having somebody in the system that is a medical home that is taking responsibility is, I think, sort of the core element that I think we need to find a way to promote more in our health system and move away from like a conveyor belt type mentality.
Transactional care. So I know you've got an answer to that, but we also promised we would take questions from the audience and also folks who are dialing in. Paul.
When I was traveling the country and visiting primary care practices, which I stopped doing, when I was traveling and visiting primary care practices, which I stopped doing 5 or 6 years ago when I retired, it used to just break my heart. I mean, they were spending a third of their time doing the two things they should do: difficult diagnostic dilemmas and relationships, which are the only two things they should be doing, because they were so wrapped up, in scribing and all those kinds of things. How much has the last 5 or 6 years changed that with technology?
Well, I'd like to say that it's changed a lot, but it probably hasn't changed as much as it will over the next couple of years. So I think, Paul, what you're describing in many ways is the hunting and pecking that most primary care providers have to do in the electronic health record. And then the documentation challenges that occur in having to write notes just so that they know the next time they see a patient what's been happening, or for their colleagues. I think over the next few years, what we'll see is an explosion in the ability for advanced analytics and AI to start to summarize the medical record so that, to your point, that primary care physicians can spend more of their time chatting with the patient, getting to know them, having that trusted relationship, that longitudinal relationship, and perhaps even having various technologies listen to the conversation with consent, listen to that conversation and be able to write those notes, maybe even help facilitate billing automatically. And I even identify things that ought to be closed from care gaps point of view. So it's a great question. I think the next few years is going to look very different than the last several years in terms of technology. But there are lots of folks, including us as well as our peers, who are looking at various ways of making technology actually lower the cognitive load, lower the physical load that primary care physicians are on. The trick will be, how do you prevent those folks from asking primary care providers to see twice as many patients? It's going to be really around how can we have a much deeper relationship with our patients so that we can optimize those outcomes that we all want. That's for all of us to figure out how to do.
Super. I think we have time for a couple more questions, if there are any online or in the room. I see one over here. Thanks.
No, this is fantastic. Arlene Bierman from AHRQ. The question I have is, I'm a primary care physician and a geriatrician, and this is Medicare. And a lot of primary care docs haven't had the opportunity to get adequate training in geriatric competencies. And I was wondering, is that something you focus on, and what kind of support? And would that actually help the ACOs perform even better?
So we do partner training with Alidata, and we work with our clinical engagement team to definitely work towards what can we work on chronic conditions that will help enable these patients function better, basically, and how is that going to portray with the accountable care organization, and how we're going to look at and helping those patients. So our goal in training new practices and ACO work is to help them understand the fundamentals that we do with annual wellness visits and getting their chronic conditions coded and managed appropriately. So once we're able to do that, we're able to really risk stratify our patients, then we can employ the different strategies that our ACO has in place to give the patients the right care at the right time. So there's multiple different things that we can do to aid patients in with dementia strategies that we're working on right now, CHF, COPD. We're looking at multiple different avenues. The most important thing that we can do is help patients understand their end-of-life issues with our comprehensive advanced care planning program that we have, and help them understand how to get the care that they deserve at the end of life. So with the patient's fundamental understanding of that makes a big difference, along with getting that information over to the patient's family or with the patient's family, really helps engage that. So there's multiple different strategies that we employ to help practices understand their chronic condition engagement strategies there.
Well, and what I am also hearing is this is a program that is made available across many, many practices across the whole state of Louisiana.
That's correct.
Because you have a centralized way to distribute that kind of programming. So you still have community-based practices, but then they have the opportunity to avail themselves of these programs that can help these particular patients. So
absolutely. Just being a patient of the ACO, being a patient of that practice that's within an ACO, it's the benefits that come along with the ACO that can provide for the patient population.
Thanks so much. Okay. Any last questions on the web, or should we transition to the next looking? Okay, go ahead, Todd.
Coming in from the live stream, what advice or resources would you have for states or regions that haven't gotten the primary care message? So this speaker says she leads a CIN in a rural state that's trying to deploy a state-focused ACO, and the importance of primary care has been devalued in the rollout.
Anthony, go for it.
As somebody who comes from state-based advocacy, I think it's important to set goals, right? I think there's been a lot of conversation about setting a goal for how much we spend on primary care. That right now it's 5 to 7%. That is, I think most people are shocked when they hear that, given how much that is their entry point to the healthcare system. That's also remarkably low compared to international in terms of 13 to 15%. Some states, including the one I came from in California through their Office of Healthcare Affordability, California just set a target of 15% over the next 10 years to increase its primary care spending in the context of a cost growth commission to try to deal with the overall cost of healthcare. And that's the other piece that this is important because it's better for the patient's experience. It's important to try to improve quality. But the thing that I think is getting most people's attention is that this is critical for the goal of getting to affordability, which, if anything, that this election that we just had was a mandate for is about affordability. And people are struggling under all sorts of costs, but they've been screaming about healthcare costs for not just years, but decades. And we need to address that and provide savings for people. Over 100 million Americans have medical debt. Folks are really struggling with the cost of coverage. And if primary care is a way that a little bit of investment here can provide broader savings there, that can get the attention of, I think, political leaders across the aisle, because it is such a widespread issue that we need to deal with as a country and each state individually.
Well, thank you. Please join me in thanking our panel. They were terrific. Okay, and now we're going to transition to the next panel and consider how, through policy change, we might grow the number of primary care-centric MSSP ACOs. And we're going to welcome Larry McNeely, Director of Policy, to moderate this conversation and introduce the other panelists.
Well, folks, that was an extraordinary panel. I just want to talk about it for all the time. But first, I'd like to welcome MyFOM, the CEO of the Institute for Excellence in Care. Welcome. MyFOM is the president and CEO, again, as I say, of the Institute, a nonprofit that's dedicated to transforming healthcare for people with intellectual and developmental disabilities. But Mai is no stranger to these issues. She's been Chief Innovation Officer previously at the CMS Innovation Center, where she was a founding official, and the architect of foundational programs on accountable care organizations and primary care. Next, I would like to bring up to the stage Frank McStay from the Duke Margolis Institute for Health Policy. Frank is Assistant Research Director on the Healthcare Care Transformation team at the Duke Margolis Center of Health Policy, where he focuses on payment and delivery reform. Previously, Frank has been a Senior Policy Advisor and Health Policy Advisor at Baylor, Scott & White. So, to get right into it, and I thought the last question was a great transition to think about the affordability that could be provided to consumers and the nation overall. I can just confirm, having been on the Hill earlier today, that indeed there's bipartisan interest in primary care as a solution to this. So that's what we want to get into. And the report released today, nice report, outlines 10 distinct policy options that relate to the findings of the report. You're going to have to pick your favorite children here. Which of these do you think are most important, and why?
Well, I think you kind of cued me when you said affordability, because I could not agree with Andrew more. I mean, the cost of care is prohibitive, and folks have insurance, but they often can't afford to avail themselves of the services. So they're not even getting in the front door because of high copays and high deductibles and everything else. So in terms of the policy prescriptions, I think for any new model of care that we're trying to incent beneficiaries to participate in. We really need to consider waiving beneficiary copays. They are a barrier to patients availing themselves of the care that they need, and which down the road will help us save money for the Medicare program. And most people have Medigap coverage, but not all, and those coverages vary. So that would be a really important issue for affordability and really important for the beneficiaries. I think a second one would be to think about, how to make primary care-centric ACOs even more attractive to folks either entering the program or wanting to expand in the program and stay in the program. I think there's a couple of things we could do. We could move to higher percentage of savings for primary care-centric ACOs. Right now it's a 50-50 split. Maybe we want to reward them even higher because they're doing incredible work and they're performing very, very well. Also, some want to move to take on higher risk. So primary care capitation, that's not a pathway that's available right now in MSSP. And finally, I think we need to expand the kinds of services that are available within MSSP for beneficiaries and consider how we could incent within the MSSP program things like behavioral health integration, which again can help improve population health and reduce costs. So those would be my three, Larry, if you asked me to select among the bunch.
Excellent. And so, again, thanks for being willing to do that. This question I think I want to direct to we heard from David about the distribution of performance within ACOs. There's also an incredible distribution in different settings of delivery of primary care in this country. Let's take a look at the independent practices or clinics. And Dr. Menard's, who we heard from, his performance was exceptional. But the small businesses and nonprofit clinics that are often the backbone of primary care access, particularly in rural communities, underserved areas generally, a lot of folks might think, the existing fee-for-service system is the only thing that can work in some of those communities. You've been a leader at CMS, private sector as well. Would the policy options talked about in this report, would they be of assistance to those kind of practices?
For sure they would. I would say, though, that there's a lot more we could do. Okay. So just to take a step back, I'm going to piggyback on one of your intros to Anne, which is, affordability, absolutely. I also want to note that despite the progress that ACOs have made, the country as a whole is experiencing plateauing life expectancy and actually a decrease in life expectancy for those in the prime years of their life. They're not in Medicare yet, but it doesn't bode well, right, for the future. And so I think this is about people and harm that people experience in the absence of primary care. When you talk about particularly access-challenged communities, there was a reason that at CMMI we invested in the advanced payment model and the AIM model to infuse investment dollars just precisely to those types of ACOs. And what we found with the AIM model was that actually really did jumpstart their performance and help them to get to savings enough to qualify for expansion, which is a tough threshold to meet under CMMI statute. So we know that they can perform. It's a matter of keeping your eye on where you're directing the program's investments. And I know we may get into this related issue later, but it is a zero-sum game in some ways. Okay, there's a benchmark a financial benchmark for the program as a whole, and how much you offer certain ACOs depends on how much you don't offer other ACOs and who else is being an ACO or not. And we can talk about that more, but I think as you think about solutions for some of these communities, you have to keep in mind that, you know, if you're committed to supporting them, you're going to have to take something away from somebody else.
It seems like, but it does seem like if this has been the engine, the MVP of MSSP, this idea of primary care centricity, that if that's been the engine, why aren't we seeing more of it? Well, then we got to shift some resources to what's actually working. Frank, question for you. In a prior role, you worked with a major health system that was, with all the differing incentives that can come into play, was striving to improve and was committing and is committed to transforming. What were the barriers to fully embracing primary care centricity? I mean, given that we know 60% of practices, the report says 80% are owned by health systems or other entities, 80% of employees, of physicians are employed by one of these entities. What policy steps can help Medicare beneficiaries get more out of primary care centric ACOs when it is a system-based ACO?
Yeah. It's a good question. I think there's a structural issue here, just acknowledging of workforce, where we want more primary care physicians, even in health system ACOs, but there's just not enough. I think there are other things, though, that kind of bleed into the unfortunate reality that there aren't enough work for primary care physicians. High panel size, like we were talking about on the last panel, where I have a friend who's a primary care physician, and it's 30 patients every day, 15 minutes, a fee-for-service hamster wheel, unfortunately. My wife is a palliative physician. It's much more of a relaxed pace where she can manage the conditions. But again, I think this all comes down to, or not all, but a lot of it comes down to a workforce that just hasn't been invested in necessarily, and it's hard to get a primary centric ACO when you just can't draw on it. I think there are policy solutions to that, though, especially in the long run. One of which is decreasing administrative burden. So we talked about the last panel about technology, but in general, I would say just giving primary care clinicians, not just physicians, but resources they need to manage population health and be the primary care physician, the high value primary care physician that they want to be. Again, I go back to my friend, when he has a medical assistant in his office that can help with notes and can help manage the patient, give that patient the resources and be a primary centric physician, it's a much easier day. He feels more fulfilled. When he doesn't have that medical assistant, doesn't have the resources he needs, it's a much harder thing to do. Again, the last thing I'd say about administrative burden, though, is a lot of this goes back to a fee-for-service unfortunate chassis that we're still on in a lot of ways. And so giving the ACO the resources they need to get the primary care physicians and clinicians the resources they need to actualize their team, everything from community health workers and medical assistants, embracing technology to help with note-taking, and honestly, stopping some of the pervasive kind of fee-for-service activities, everything from risk adjustment coding to clinical document integrity, letting the physician do what they do best.
You know, it just crystallized for me the comment earlier from Anthony about we don't want a doctor on the hamster wheel or a patient on a conveyor belt. And if there's a simpler way of expressing kind of payment system pre-ACOs, pre-payment transformation that we built, I don't know one. So let's now shift to the real world of Washington, D.C. here. And as we have a new administration and a new Congress, what policies related to MSSP and primary care do we think will be up for consideration, could be up for consideration? And how collectively can the community of folks who care about this bring those ideas forward? And this is for any one of you.
I thought you were going to ask, what did we think should happen? Which would be an easier question to answer. So I'll hedge a bit because I'm a terrible prognosticator, but I think it is important to lay out what the unideal path might look like, and then that's our opening bid, and we negotiate down. I think several things come to mind. One, one of the things I observed listening to David's presentation was that, and he explained to me, we just don't have enough data to do the kind of finely stratified policy making that we need to in terms of what the makeup of these different ACOs with different performance levels are. We don't actually know who is in a hospital system and who is not in terms of ACO providers. And we also don't know very much, frankly, about beneficiaries' experiences in ACOs. I don't think a CAP survey tells us very much. I think we need to know what is their level of trust. Is that correlated with the performance of the ACO? What can be done about that? How are the successful ACOs approaching relationships? So there's a lot more to be learned, and I think policymakers should encourage that. I would also say, again, this is a theme. I don't want to burst bubbles, but the performance is great. It will hit a brick wall at some point, and possibly very soon, because the way that actuarially the benchmarking occurs for ACO programs is that CMS, the actuaries have to believe that there will be a net savings to the program, which means that you're really working with the dollars that the ACOs themselves bring into the system in terms of the services that they provide. If you have a group of volunteer ACOs, you've got ACOs who are trying to generate savings and improve care. What you don't have are the organizations that are not trying to do that, that in fact are out there trying to leverage fee-for-service and growing the system costs. So over time, you have a group of well-intended organizations fighting increasingly so over a limited pool of potential savings. That is not a sustainable mechanism. Neither does it send a very rational signal to the marketplace. It is not saying, if you perform well, we will reward you the way that Medicare Advantage does. If you perform well on STARS, next year, here's what you get, in terms of premiums and blah, blah, blah. That doesn't happen in ACO programs. So I do think that there is a point at which policymakers have to ask themselves, are they really serious about affordability and sustainability? Because if they are, ACO programs have started to become mandatory. Not necessarily for everyone, but we have enough data to know which organizations are generating more spend per beneficiary in the program. And if they are not an ACO, they need to become one with a reasonably paced track to downside risk. So that's one, not prognostication, but wish list item, I guess.
Okay.
And I think another is to several, panelists' points about getting off the fee-for-service wheel. The structure of the payment makes a great deal of difference, and that population-based payment structure that would give practices and ACOs the revenue flexibility to make the investments they need to make. As much as possible, when it's primary care capitation, it should flow to the practices rather than, get stuck at an upper layer and then they are still being paid fee-for-service within their own organization. That does no one any good, really. And that, unfortunately, is what is happening in most ACOs today. And then the third thing people have referred to is the pricing. And again, there, under current law, Medicare statute has a budget neutrality component. That means that if you want to spend more on primary care, you're going to have to spend less somewhere in the physician fee schedule. And policymakers have not shown the political fortitude to take on that issue in a meaningful way. But you talk about that being a burden for primary care, not just in terms of, this is why the workforce is constrained. It doesn't matter how much a hospital wants to pay a PCP, they are limited in the revenues that PCP can bring in. It is also a burden in that the other services that are so attractive from a profit margin perspective. That generates the headwinds for PCPs who are trying to do the right thing by their patients. Medicare, traditional Medicare, is the country's largest PPO. Patients can self-refer to specialists, and many proceduralists, they have hammers and they're looking for the right nails. And even if they're well-intended, you know, if you are a GI doc, then chest pain to you means reflux and requires endoscopy. It doesn't necessarily mean a panic attack or a cardiac problem. And then you go to a cardiologist and your dizziness is likely AFib or some kind of rhythm that requires a Holter monitor, you know, or electrophysiology, as opposed to, maybe you need to practice with ankle weights and improve your balance. So primary care is the only place in healthcare where this very hard cognitive work of integrative diagnosis and assessment and ministering happens. It is the only place in medicine where the person is a whole person and not a series of organ systems. So that's why I think that, you know, at some point policymakers have to do something or get off the pot, you know, in terms of deciding how much does affordability really mean to them.
Well, I mean, I have nothing to add to Mai's incredible range of things that we would hope policymakers will do. And they are, I mean, you're an incredible visionary. They are very ambitious. I would say that I think there are some things that they may do in the coming couple of years in our conversations on Capitol Hill that are, you know, steps in this direction, but not nearly as expansive. I do think there's some appetite for figuring out how to incent behavioral health integration. I do think there's some appetite for, you know, more risk for primary care within MSSP, ACO. So I think there are some steps, but you are exactly right that there are fundamental things that are much more ambitious that need to be done. Now, we've promised our folks here in the room and that we would open it up for questions. So back to you, Larry.
Thank you. And we're going to open up, as I say, questions for folks in the room. If you want to raise your hand, we'll have a mic come to you. Dr. Howard Haft looks to be first on the uptake, and we also are taking questions online that the team might share with me.
Yeah, thank you very much, Larry. Howard Haft, University of Maryland School of Medicine. So the question again is similar to what Mai said. Let's, you know, put our top bid on the table and negotiate down from there. I think it's really evident from the previous discussions and everything we know that technology now has become a critical part of the delivery of care, particularly primary care. We're incapable of delivering the kind of care that we need in a population base or individual base without technology, but it is very, very expensive and one of the barriers to care. And I know that it may be ultimately an issue that we need to address in a policy manner, that is perhaps to be able to democratize some of the data that we have now. There's I know within CMMI models, there's now a great deal of interest in multi-payer data aggregation, particularly using other external sources and potentially even EMR data in that. And it would be really one of the great boons to the availability of healthcare to delivery, to be able to have that more freely available to primary care particularly.
Panelists have a reaction to that? Frank?
I can start. Yeah, I think we've seen CMS take some steps here for primary care, i.e. providing shadow bundle data to primary care physicians about specialty performance in their area. And I know there's interest in kind of making a 2.0 of that. I'd agree, like EHR data beyond that, like, it'd be wonderful if you didn't have to risk code as a primary care physician. We could just extrapolate it from APIs and TEFCA, so there's no burden there. I think there's a lot of interest in that, and I agree kind of what the earlier panel was saying, that the future in the few years is bright, but I would emphasize what you were saying, that those probably need to be paired with more sincere efforts for more advanced payment models, potentially mandatory. They need to be paired generally with kind of beyond data, giving more of an emphasis to use those tools.
Yeah, and I would just echo your caution about efforts like that, Howard, not generating more administrative burden. I think, you know, to your point, Anne, what is feasible? I think it's very feasible for CMS to take steps to reduce administrative burden even more and simplifying programs even more rather than embellishing them at this point. We really don't need 32 quality measures. We really don't. And you know, if you have demonstrated performance, perhaps there could be a dose response reaction from CMS as well, in terms of both the shared savings available to you and the administrative burdens.
All right, other questions? You know, other questions? I think I have a few myself. Let me tell you. You know, it's come up a few times, this point about needing better data at CMS's level to do the refined assessment of what's actually working. I think Mai raised that. It's certainly part of the recommendations of the report. And do you want to share a bit more about the policy areas that need to be changed to support better research and data and guidance that really could get to the issues we're raising?
Well, and I'm sure my colleagues have ideas as well, but you know, in terms of the workforce data, understanding more about who's practicing in primary care versus specialty care for NPs and PAs. And so incident billing, you know, is problematic in that we don't actually know who's providing the service. And so, you know, addressing that, it's a vestige from when PAs and NPs couldn't bill directly. So, you know, I think we need a clearer picture because right now it's very fuzzy. And so steps could be taken there. And I think, you know, that's on the administrative end. It wouldn't require statute. You know, this distinction between low and high revenue ACOs also seems to be getting pretty murky with a lot of, you know, reorganizing of TINs, et cetera. You know, maybe we need some basic data, which I think Anthony had put up, which is, you know, what are your expenditures on primary care as an ACO? What about your E&M codes, which we know generate so much high value? You know, what proportion of those are being done by primary care clinicians? What are your expenditures on behavioral health? So some of the metrics that we know drive better performance, couldn't we have a composite measure of those to understand something more about the ACOs? So I think we need to think about a different way to characterize ACOs and get a better handle. I'm lifting up the characteristics that we know are tied to better population health, lower costs, and have a metric to report that.
Yeah, I definitely agree with all of that. I would also say, you know, we don't know, we can only conjecture, we only have anecdotal evidence about how PCPs on the ground are being paid within ACOs. And that seems like, while it may be complicated, and I know that ACOs will cry foul for a good long time because we tried to do it, but it's a thing that's knowable and reportable. And I think it would improve transparency. And I think that ACOs can learn from one another if they had that information.
Agreed.
Thanks very much for that. And I think that is going to, we're at time for the afternoon. Mai, Frank, thank you so much for being part of the conversation today. And I'd like to hand it back to Anne for final thoughts.
Thank you. Thanks to the fellow panelists and Larry for your very skilled moderation. Thank you all who are here in the room for joining us and those who have joined us on the web. You can download the report. It is up on our website. We have paper copies for those who are in the room. You can take a couple back to the office if you'd like. I hope that you get this report out on social media. We certainly will be doing that with our partners, and we really appreciate you coming today. We think it is a very policy-relevant report that we hope informs conversations after they get over tax, and turn their attention to Medicare payment reform next year. So thanks all for being here.